This is a WDIO News Special Report.
Simply press star, then the number 1 on your telephone keypad. If you would like to withdraw your question, press the pound key. Thank you. I would now like to turn the call over to Mr. Michael Schommer. The floor is yours.
Thank you for joining us for the COVID-19 media call for October 21st. We'll start today's call with comments from Health Commissioner Jan Malcolm and MDH Infectious Disease Director KRIS EHRESMANN. Following that, we will be hearing from Christine Lees, last name Lees. Christine is the Public Health Supervisor for Disease Prevention, Control, and Emergency Preparedness and Response with Dakota County. We'll also be hearing from Laura SCHWARTZWALD, co-founder of Central Minnesota's GUIDEPOINT Pharmacies. Christine and Laura have been partners with MDH as we've worked on plans for the COVID-19 vaccines on the way. After that, we'll open it up for questions from reporters on the line. So we'll get started this afternoon with Commissioner Malcolm.
Thanks, Mike, and good afternoon, everybody. Yesterday, 60,000 additional cases of COVID-19 were confirmed in the United States, bringing us to a new total above 8.2 million cases in our country. And sadly, 949 more Americans died yesterday from COVID-19, bringing our country's pandemic death toll so far to more than 221,000 of our fellow people. Here in Minnesota, we added another 1,079 confirmed cases yesterday on a volume of 15,733 tests, bringing us to a new total of 126,591 laboratory confirmed cases in Minnesota. 1,047 of yesterday's cases were PCR positive or confirmed cases, and 13 of the cases were probable cases or antigen positive cases. Very sadly, we tied our record high for deaths yesterday, with 35 of our fellow Minnesotans having died. That brings our total to 2,281 deaths in Minnesota. These people lived in 15 different counties and ranged in age from their 60s to over 100. There were 25 more people in the hospital yesterday than the day prior, 558 total, 162 of those in the ICU. We've been dealing with this pandemic for many months now, and we've been talking about these numbers many, many times. And the numbers can be a bit numbing, but I'd really like to focus in for a moment on that number of 35 deaths. Imagine the heartbreak that is behind each one of those deaths. As I mentioned last Friday when we set the new record for most cases in a day, we're deeply saddened and alarmed by these numbers, but frankly not surprised to see this happening. We've known that a surge in deaths was to be expected several weeks after we see a surge in cases. And the numbers for our cases in Minnesota, as we've discussed, have been rising at a faster rate. And while we celebrate the fact that our healthcare providers and researchers have made really genuine progress in getting better at treating COVID cases, we do need to understand that more cases are going to lead to more people with serious disease, potentially with long-term complications we are only beginning to understand, more people in the hospital, and more deaths. We need to brace ourselves for that. And more to the point, we really need to get everybody in Minnesota to understand the trajectory we're on and where that's going to be taking us unless we make some changes. We need everybody to understand what these numbers mean and not just, listen to the numbers every day and take that as our new normal or as a given or something we can't do anything about. We need to understand the meaning behind these numbers, and if this continues on the current trajectory, what the impact is going to be on individual Minnesotans, our families, our workplaces, our schools and communities. COVID doesn't just happen to the one person who gets affected. Even if you don't get seriously ill, you're likely passing that illness along to others in your own household and in your community, and you have no way of knowing where that's going to lead or who it's going to strike. A decision to not stay home when you're ill, to not get tested, or to go to a gathering, to not wear a mask, isn't just about you. It's about all of us. It's about the entire state and what kind of next few months we're going to have. And this is not just a conversation we're having in Minnesota. We're seeing the same kinds of numbers, the same kinds of conversations play out, you know, in all of our neighboring states, and indeed in most of the country now, as we've seen in recent days. And we've seen what can come next when growth rates get to this level and keep on accelerating. Today, we hear that North Dakota health officials are so overwhelmed that they're asking residents who test positive for COVID-19 to do the work of informing their own close contacts rather than having that task handled by public health. In Wisconsin, we hear reports that the hospitals are close to overflowing, and the White House Coronavirus Task Force says that Wisconsin is now the 4th worst state in the nation for the rate of new infections. In fact, 8 of the 20 worst hit metro areas in the country are in our next door neighbors in Wisconsin, according to one tracking tool. Now, we're not at those levels yet here in Minnesota, but the numbers we're seeing show that we could very well be on the road to that same kind of trouble. And we just really need to make it clear to everybody what that means. It means major impacts on our healthcare system. And we've talked about this before, but I just want to reiterate today some of these really key things for all of us to keep in mind. When the healthcare system gets overwhelmed, it doesn't just mean that you or a family member or a loved one who gets COVID might have trouble getting the care they need. It's also true for people getting a wide range of other health conditions, having a heart attack, having cancer, breaking a leg, getting sick or injured in any way. And it's not just about, do we have enough hospital beds? We talked last week at some length about the fact that it's about whether our healthcare workers stay healthy and safe and able to provide care. Not having enough staff to provide the care for the people in those beds is the real risk that we face in the near future. We can look to major impacts for our schools. Students who get sick or are exposed are not then able to go to school, to play sports or engage in other activities. Schools need to move to remote learning because too many students or too many teachers are sick or have been exposed and need to isolate or quarantine. It means major impacts for our elderly and other high-risk groups, not just more illnesses and deaths in these highly vulnerable populations, but also impacts to their mental health and social connections due to fewer opportunities for visiting loved ones in long-term care settings if we need to not be able to move forward with expanded visitation guidance when better controls are in place and when the level of disease is lower. We know what a critical, important goal that is for residents and families to be able to visit. We can look forward to major impacts on our workforce and business community to these continuing case growth numbers. Workers not being able to work because they are sick or have been exposed and need to isolate or quarantine, which could very well lead to businesses not having enough people to stay open and operate. And we know that so many of you already understand this. We're just repeating things we've said many a time, and the great majority of people in Minnesota are doing the right things to help limit COVID spread. But we all know that not everybody either understands or believes that these precautions are necessary. In some cases, this may be due to their feeling that the choice about COVID is a personal one, that is theirs to make, which doesn't affect anybody else around them. But obviously, we in public health see it differently. There's a good reason that the people who lived through World War II are called the greatest generation. Not only their efforts on the battlefield that literally saved the world, but also for the work and sacrifices of those here at home. During that time, we saw a spirit of unity and purpose and a focus on shared goals that maybe hasn't been as clear to us in more recent times. But we're at a time again when there's a need for all of us to work together toward a common goal, a time to really think about the value of tolerating some personal inconveniences and desires to address a major threat to our entire state, indeed our entire country. This is a historical challenge for our country, for our state, and for our individual communities. And in years to come, I think we all want to be able to look back and say that even though we may not have agreed on every policy or every decision, we did our part so that our elderly family members and neighbors would stay healthy and alive, so the child with asthma could go to school, and so our businesses could stay open and operate safely. I'm really thankful, genuinely thankful, that most Minnesotans who have tested positive for COVID-19 have not become seriously ill. That is a fact. But it's also true that those who did not become seriously ill doesn't negate the fact that so many Minnesotans have become seriously ill, and that the folks who didn't become seriously ill passed the illness along to others who have had much more serious consequences, and that many people are suffering long-term health effects from the virus, and far too many have died. And those numbers are only going to continue to grow if we don't all take action now. We know 8 months is a long time to postpone milestones, gatherings, so many things that add to the quality of our lives. But the majority of us are finding the will and finding the way to stay that course, to wear a mask, to keep our distance, yes, to postpone or reimagine their important celebrations, birthdays, weddings, memorials, family traditions, graduations, so that these larger goals can be met, so that kids can go to school, businesses can stay open, families can visit their mothers, fathers, and grandparents. But you know what, to beat a pandemic, a majority isn't enough. Now more than ever, we need literally all of us to be part of making these personal, individual efforts to keep every other Minnesotan safe. We really need to think hard about the kind of impact that we are having on the shape of this trajectory. We need to believe that it's in our power to bend this curve and to shape what's going to happen over the next few months as we wait and work to be able to take advantage of the better days that are coming. It's hard, but it's not complicated. The things we keep talking about, when you think about it, are low cost, low tech, and require no special skills. If we all do the things that we know matter and help to prevent and limit the transmission of the disease, we will have a far different and far better next few months until we get to that time when safe and effective vaccines are widely available. And with that, I'm going to turn it to KRIS EHRESMANN to update you on the progress we've been making on planning for vaccine distribution. KRIS.
Thank you, Commissioner. I say amen to everything you just said, and I'd like to talk a little bit about a vaccine planning, and hopefully that will provide us with some hope as we double down on our efforts to prevent transmission. We've talked for months now with growing hope about the prospects for a safe and effective COVID-19 vaccine. It's been impressive to see how quickly vaccine development has gone, and we now have 4 vaccines in advanced stages of trials. It's too early to say exactly when the first vaccine will become available to Minnesotans, but we are optimistic that there will be 1 or more coming in the months ahead. No matter what, our pledge to all Minnesotans is that we will move forward with a vaccine only when the evidence shows it is safe and effective. It's important that we have a strong plan in place to effectively distribute a vaccine when it is ready, that we can effectively communicate how and when to get it, and that we make sure Minnesotans are confident we've done everything possible, that it is both safe and effective. Our vaccine planning is based on several key priorities. First, any vaccines distributed in Minnesota must meet the same exacting science-based standards of other vaccines. This means thorough vetting and review by independent third-party experts before it is used. We will take our lead from the Advisory Committee on Immunization Practices, a national independent committee who will only recommend a vaccine that has met the safety criteria and fully intend to move forward with vaccinations once we know it's safe. Second, we must ensure that the distribution and availability of the vaccines is fair and reflects Minnesota's priorities and values, especially in the early weeks when availability is limited. Third, the public sector can't do this alone. We have to build and maintain trust with communities, and they must be partners in both the planning process and the distribution of the vaccine. We are already working closely with community-level leaders and members who will continue to, and we will continue to do so to get out the vaccines and to get information out about the vaccines, including their safety, effectiveness, and availability. We know the most effective approach is going to be based on partnerships, especially with Minnesota communities suffering from health disparities. Late last week, Minnesota and other states submitted draft vaccine plans to CDC. This in-depth 40-plus page, but still draft plan was the result of some great collaborative planning, not just with MDH and state government, but also with local public health, healthcare, and others. Today, we're providing a brief overview of that plan. We're pleased to be joined by two of the partners representative of the many people from across the state who have been and will be very important in this process. It's important to note that the COVID-19 vaccine planning is built on the foundation of many other successful vaccine distribution efforts over the years, from H1N1 to measles to childhood immunization efforts over the decades. Our draft plan provides a framework for our vaccine planning, a bit like the frame of a house before the siding and the sheetrock have been added. There are still a lot of unknowns related to COVID vaccines. And so the plan we submitted provides that framework, but we'll be adding additional details as we learn more about the vaccine that ultimately will be rolled out. Right now, there are multiple vaccines in various stages of phase 3 trials. That is the late stage or large group trials. This means we have to be prepared for multiple vaccines with different specifics around approved at different times. One of the implications of this is that vaccine availability and volume will vary as vaccines are coming online. We're working closely with our local public health and tribal partners in planning, as well as regional healthcare coalitions. The draft plan covers many different areas, from vaccine storage and handling and allocation to safety monitoring to interactions with critical populations. We will have an executive summary of the draft plan posted on our website. A few points I want to emphasize. As the playbook states, the expectation is that vaccine will be provided to Minnesotans at no charge to them. Also, we want to stress that initial supply of vaccine is expected to be limited and therefore will be prioritized for populations most at risk for COVID-19. We plan to be transparent on how these prioritization decisions are made and are committed to equitable distribution of safe vaccine. We are working to identify critical healthcare employees and other essential workers in our state. We await additional guidance on prioritization of limited vaccine from the CDC's Advisory Committee on Immunization Practices, or ACIP, and the National Academy of Sciences, Engineering, and Medicine. We are planning to roll out the vaccine in phases to these prioritized populations as more and more doses become available. We will share more information with you on what to expect as we learn more. One thing that I do want to talk about is misinformation and concerns. As part of our distribution plan development, we're engaging with many stakeholders. Listening to their concerns and views on vaccine distribution needs will help us develop strategies to increase confidence in COVID-19 vaccination. Poll data have indicated that many Americans share concerns about a COVID-19 vaccine. It's natural for people to have questions around a new vaccine. We in public health plan to address those concerns with facts about the vaccines, how they were developed, and the independent scientific reviews that were conducted. All this needs to be communicated in ways that are easy to understand and easy to access. And the most effective spokespeople won't necessarily be people like me. It will be family doctors, community leaders, and other trusted sources in people's everyday lives. We have established a COVID vaccine allocation work group made up of a diverse membership from multiple sectors. The charge of this group is to take the federal guidance on vaccine priority groups and tailor it for Minnesota. When complete, a written plan will be made publicly available. In all of our planning, safety is a priority, as I mentioned. We were very encouraged by the FDA announcement earlier this month that they expected to see 2 months of post-vaccination safety data for half of trial participants before they would consider any vaccine application. Before I wrap up, I just want to mention again that the plan that we submitted is draft. Our plan is a living document, a compilation of strategies based on what we currently know about multiple vaccine candidates, and it will change over time. We'll continue to add specificity and detail as we learn more. And with that, I'd like to turn it over to Christine Lees from Dakota County.
Thank you, Chris. Good afternoon, everyone. I'm going to be sharing with you a little bit about our efforts on vaccination planning at the local public health level. At Dakota County, we started our COVID-19 planning back in late July. There's several vaccine planning work groups at the state and local level that we are participating in. And it's very important that we are coordinating our efforts with MDH and with the other counties in our region. This effort to make vaccine available to everyone who needs it in our community will take all of us working together to make this happen. Local public health has a key role in assuring COVID-19 vaccine reaches specific populations in our community. Our phase 1 planning is currently underway. We are working to identify who will be administering COVID-19 vaccine to the populations most likely to be identified for those first doses. This will likely include long-term care, skilled nursing facilities, assisted livings, adult group homes. Our work on providing testing services to these facilities over the past several months has helped create partnerships that will transfer well over to vaccination planning. We will also be working with partners in our community, including nursing agencies, pharmacies, and primary care clinics to help ensure phase 1 populations have the access to vaccines they need. Another key group in phase 1 vaccination will be our healthcare workers, particularly those providing direct patient care. We are working with the Regional Healthcare Coalition, which includes hospital emergency preparedness partners and local public health partners. The hospital preparedness partners will be taking lead on many of the efforts around healthcare vaccination clinics during phase 1, and local public health will continue to work in partnership with them. Local public health is also planning for what we call mission critical workers during phase 1. This may include groups such as some of our first responders, our emergency medical service providers, or other staff such as public health nurses running the vaccine clinics. Other groups may be identified as mission critical, but we do not know the final list yet. We are planning to help run public health clinics for mission critical staff during phase 1. Another key area of planning involves how to provide vaccines to hard-to-reach populations in our community. Local public health traditionally plays an important role in providing community-based vaccine clinics that remove access barriers for people in our community. This includes reaching those who are uninsured or underinsured, people that may have mobility or transportation issues, people without access to a healthcare home due to a variety of reasons. We are planning on creative ways to reach these populations, including hosting mobile clinics and drive-through community clinics. We want to reach populations where they are at, similar to what we do for immunizations with influenza. We are starting our phase 2 planning also. This phase will have some similarities to the vaccination clinics that we planned and ran during the H1N1 pandemic. We ran what we call open points of dispensing, which is when we are able to vaccinate thousands of people through larger clinics staffed by many people in larger settings. We've been planning for an emergency response like this continually for the past several years, and we have plans in place for this that we are utilizing. We are working with partners and county staff to assist with planning for some of these larger clinics, so we are ready when vaccine becomes more widely available. Local public health jurisdictions will be submitting phase 1 vaccination plans to the Minnesota Department of Health in November. We will continue to be working closely with Minnesota Department of Health and with our other local public health partners to make sure we are coordinated in our planning
and are as prepared as possible to deliver COVID vaccine safely and efficiently to our community. And with that, I will turn it over to Laura.
Thank you, Christine, and hello, everyone. My name is Laura SCHWARTZWALD. My husband and I, as stated earlier, are co-founders of GUIDEPOINT Pharmacy, a group of community pharmacies located throughout Minnesota, mainly in rural settings. I became passionate in the area of immunizations and pandemic preparedness several years ago when I served on the Minnesota Board of Pharmacy. It was at that time that I became a pharmacist member of the Minnesota Immunization Provider Advisory Committee. Additionally, I served on several work groups and advisory committees at the national level for pandemic preparedness, hosted by the National Association of Community and City Health Officials. My primary role in many of these committees was to provide input and feedback as a full-time practicing pharmacist at the community pharmacy. We are providing immunizations both in our stores and through immunization clinics on a daily basis. In fact, at this very minute, we are out in our community providing flu shots to residents residing in area assisted living facilities. Minnesota is fortunate to have many well-qualified and devoted vaccinators who will be very important to the success of the state's COVID immunization campaign, and pharmacists will be among those partners. Utilizing pharmacist training and skills in the immunization process provides one more tool that we possess to help get more people immunized against vaccine-preventable diseases. And because most people are within reasonable access to a pharmacy, we can reach many people from many underserved areas in Minnesota where some of the health disparities are the most apparent, often because many medical facilities are not readily available. However, no one immunization partner can do this alone. My pharmacist and I have been involved in the immunization partnerships in Crow Wing County for many years, vaccinating communities of need within the county. Even before the H1N1 pandemic, local immunization providers partnered with our Crow Wing County Public Health Department on a regular basis to assess vaccine planning for the upcoming season. We identified areas of opportunities or barriers that helped us formulate a plan for future immunization crisis like H1N1. It was likely that because of these partnerships, we were well leveraged to provide the H1N1 vaccine to the people in Crow Wing County quickly and efficiently. Based on our past partnerships with public health, what we have learned so far from the flu immunization process will be the basis for COVID planning in many areas of the state. And since we are learning and improving along the way, we can use our healthcare planning and reporting skills to anticipate the timeliness and need for the second COVID-19 dose in an effort to prevent gaps in immunization coverage. In fact, we are already currently using that care planning process to identify and contact patients that may need follow-up immunizations like those for shingles. We then try to schedule them for all of their other immunization needs. This is notable as we've seen a dip in the immunization rates among both children and adults since the pandemic began. The COVID-19 vaccine is likely going to be a 2-dose vaccine series given from the same manufacturer in a short period of time. It's going to be a challenge that will be made easier through partnership and planning. Thank you for your time, and I will now turn this back to Chris.
Thank you, Laura. I just wanted to say something about influenza, and I thank Laura for kind of tying the work that we do related to influenza to our planning for COVID-19. While COVID-19 has all our attention at the moment, we did want to briefly mention that we are heading into flu season, and so starting tomorrow, we will be resuming our weekly flu report on our website. This report has been a mainstay of our flu data for years, posting weekly updates on what we're seeing with regard to the flu season. One bit of early good news to share on the flu front. The latest figures show a 42% increase in the number of Minnesotans getting their flu vaccine at this point in the season compared to last year. That is a great way to keep healthy and avoid respiratory symptoms that may cause you to worry that you have COVID. It's also a great way to help our state because the fewer cases of flu we have, the less pressure there will be on our healthcare system and hospital beds as we head into a winter spike in COVID cases. So check out our website tomorrow and get your flu shot if you haven't done that already. And I'll turn it back to Mike.
Thanks, Chris. Operator, we are ready to take questions.
At this time, I would like to remind everyone, in order to ask a question, press star, then the number 1 on your telephone keypad. Again, that is star, then the number 1 on your telephone keypad. We'll pause for just a moment to compile the Q&A roster. Thank you. Your first question comes from the line of Glenn Howard from Star Tribune. Your line is open.
Hi, thank you. We've seen some reports about the states saying that they won't allow the vaccine to be administered if they're not convinced that it's safe and effective. I really don't know if they can do that, but I mean, is that an option that you guys are looking at, that you might block the vaccine if the data doesn't show that it's safe and effective?
Glenn, this is Commissioner Malcolm. Before we get to your question, I just want to take a quick second to thank Christine and Laura again for joining us on the call. I know we spent a lot of time talking today, but this vaccine planning work is really impressive, and really appreciate the opportunity to share it with you. On that subject, I think one critical message is that we are all working, at the national level and with our public health colleagues around the country to closely track the developments around the vaccine, and we are reassured by what we see happening, by the work of the federal advisory committees, by the ways that the trials are being managed. I think, as Chris said, it's been our commitment that we will fully follow those developments and pledge that we will not administer vaccine in Minnesota that we don't feel is safe and effective. In terms of the logistics of how that might happen, I would call on Chris to add any specifics there.
Thanks, Commissioner. Glenn, yeah, I think the way that I would frame this is that, we put up our commitment to ensuring a safe vaccine for Minnesotans on September 8th. And there have been a lot of developments that have been really positive in terms of how planning for vaccine evaluation will happen. And so, as the Commissioner said, we're feeling really good about that. But if we were in a situation in which many of the normal checks and balances in our vaccine process did not happen, we would very much flag that and have discussions then about making sure that Minnesotans were aware of our concerns, and discussing what steps that we would take to, reevaluate our vaccination process. But as I said, we put out, our commitment hasn't changed, but we put out some of the language about a commitment to vaccine safety as, back on September 8th. And there have been a lot of very positive changes at the federal level. So the 2 months of post-vaccine evaluation, VRBPAC from the FDA is meeting, so they will be included in the process. So many, many positive things have happened. But if we sense that there is a concern, we will definitely, let people know and have conversations about how to proceed given that concern.
Thank you. And you say this 2 months of post-vaccine. As far as I'm aware, all of those trials are ongoing. And given that it's almost the end of October, does that mean that we're not likely to see a vaccine this year?
That's a good question, Glenn. Actually, one of the manufacturers is a bit farther along, Pfizer, and so it would be possible because there are the trials. It's a rolling situation, and so they can have 2 months of data on half of their trial population, and so it is possible that there could be a vaccine that is evaluated before the end of the year. But we think it's important for people to recognize that there are a lot of steps in the process, and we certainly don't want to suggest that there'll be a vaccine in the next couple of weeks or anything like that. But it is possible that there could be one. We just don't know if that will really be the case.
Thank you.
next question comes from the line of Walker Aronson from Minpost. Your line is open.
Hi all, sorry if you've addressed this recently, but I think just from a rough count of the deaths in the last couple of weeks, there have been more in greater Minnesota than in the metro. Can you just talk about that? And is there anything that you would highlight? Like, are they coming primarily from long-term care, or, you know, maybe it's not one particular situation, but is there any trends or anything that you would pull out that seems interesting to me? I know the metro has made up the vast majority of the deaths generally in the pandemic.
Thanks. This is Commissioner Malcolm. That's a great question. And before asking Chris to comment on the specifics, I'll just reiterate that I think that just underscores what we've been saying about just a fundamental shift in the dynamics of the pandemic over the recent months, that to the extent it was originally more of an urban phenomenon and more driven by, you know, specific outbreaks in certain large settings, it's really become much more now of a statewide phenomenon driven by lots and lots and lots of different sources of transmission. And I see that, and we see that reflected in the hospitalization and unfortunately the mortality data as well. But Chris, could you quantify that a little more?
Yeah, I think that it's fair to say that we are seeing more deaths in greater Minnesota because we are seeing more cases there. And in fact, our case growth at this point is greater in regions across the state than it is in the Twin Cities metro area. So yes, we're definitely seeing more deaths. And I think it's important for people to realize that the cases are occurring across the state and in greater Minnesota. This, as the commissioner said, this is not something that's just happening in the Twin Cities area at all. In fact, it's growing at a greater rate across the state. And just to keep in mind that while deaths from individuals living more in the metro area, there may be you know, a large number. You have to consider the population density as well. And I think that what we're going to see as we start to see these lagging indicators like deaths start increasing is that we will see more and more deaths from greater Minnesota because of the high caseload in that area.
And just to follow, so it sounds like it is generally a number of things causing the deaths, but could you speak to, like, is there a majority of it that's still long-term care, or is long-term care more of a metro issue?
Long-term care is an issue across the state, and as we've been seeing case numbers increase across the state, we're seeing our long-term care facilities in all parts of the state affected. So absolutely, the activity that we see in long-term care reflects what's happening in the community. And because communities across the state are impacted by COVID, we are seeing activity in all those facilities.
Thank you.
Your next question comes from the line of Greg Chapman of WCCO TV. Your line is open.
Thank you. Good afternoon. I was wondering if you think that this rise in hospitalizations and death may be due to COVID fatigue. Is that an issue, do you think?
This is Commissioner Malcolm. Yeah, it is absolutely an issue. COVID fatigue is real here in Minnesota and all around the country, and we see it in the outbreak data. What is fueling some of the case growth is just people getting together, you know, gathering with friends and families and celebratory events, and not particularly adhering to the gathering limits that are still contained in the governor's executive orders, and not particularly adhering to the health guidance around keeping social distance and wearing masks, not going out when you're sick and the like. And we've had, you know, too many anecdotal reports and reports through our case investigations of people who are sick still declining to get tested because they don't want to find out that they have COVID, and just what that leads to in terms of continued transmission if people aren't getting tested. And then even if they are getting tested, if they don't act on the information, to stay isolated or quarantined if they are a close contact of a person. So we are just seeing it in so many ways in terms of what's driving the exposures, what's driving the case growth, the fact that it's so widespread really does reflect just sort of a generalized fatigue level, which we do understand, which is why we keep, really coming back to these core points of how important it is that we not give up now on the very things that we know are successful in slowing the spread. We've heard from national leaders as well that, and KRIS just talked about, and our guests today talked about all the good work going on to be ready to deploy vaccines when they become available. That's still some time away. And there's just so much we can do to influence the course of events between now and then by, just dealing with the fact that despite our fatigue, we really need to keep up with these basic preventive measures because they work. KRIS, I don't know if you'd have anything to add there.
No, but well, I'll just say that yes, as the commissioner said, COVID fatigue is real, but we really hope that people will reach deep within themselves to move forward in a positive manner, because the cases and the deaths that we're seeing are real too, and that's really concerning to us.
Do we have enough PPE in hospital space to accommodate this rise in cases?
This Commissioner Malcolm, again, that is one of the things that we've been working on, and we've made really good progress in securing more personal protective equipment and really getting clear about how we would, free up more critical care hospital beds if needed to deal with the rise. And that's genuine progress that's been made. So we always say we're in a far better situation today to manage cases of COVID than we were early in the pandemic. But we've also talked recently about the fact that, yeah, we've got PPE, we've got, a good system of keeping track of healthcare capacity. But what's been really concerning us lately with the degree of virus that's out there, with the increases that we're seeing among healthcare workers getting either themselves sick or exposed to colleagues or to family members who are sick, and then being unavailable to care for people, whether that's in hospitals or in long-term care. So it's a potential healthcare worker shortage that is of particular concern to us too, that we can see in these case numbers rather than just the theoretical hospital capacity in the beds. So it's all of these pieces are really very connected.
Thank you.
Your next question comes from the line of Tim Blott from Fox 9. Your line is open.
Well, thank you very much, folks, for taking my question. A real simple one, and KRIS, this goes out to either you or Christine or whoever wants to take a bat at it, but you talk about the phase 1 of the vaccine rolling out, and I would imagine this question perhaps depends upon supply. But how long do you anticipate phase 1 to get to those critical care workers, the long-term care facilities, and everyone else who is on that first priority list in phase 1?
I'll start. Thank you. This is KRIS. Well, the way that the federal government and states and local public health and tribal health are looking at our planning for vaccination is really in 3 phases. And the first phase represents that time frame when doses of vaccine are limited. So it's not, a particular time frame of 3 months, but it really represents when doses are limited, and we will be focusing on targeting vaccination to certain populations, as you heard us discuss, whether that is essential workers, healthcare, critical sectors, that type of thing, as well as then looking at vulnerable populations. And so the allocation work group that I mentioned will be helping us to identify principles and kind of policies for moving forward for identifying those groups. They will be informed by guidelines coming from the federal government, but then will be tailored to Minnesota with help from our allocation work group. And then we'll take that information and apply it, and say, okay, now we've identified these groups. This is who is going to get vaccination in this limited, this time when supplies are limited. And I think it's important for people to keep in mind that during this phase, the vaccine will be very targeted, and it will likely not be in a situation in which, people could just walk up and get vaccinated. It's going to be likely in closed settings. So a healthcare setting where we're vaccinating, the workers or something like that. So that's what we mean by phase one, is at the time when vaccine doses are very limited. And you're right, we don't know which vaccines will come online or when they will come online. And that's why we've kind of tried to convey here that as we learn more information, we will add to our plan. But there is a lot right now that we don't know. But I'll let Christine also comment on the work that they've been doing to prepare for that first phase.
Sure, thank you, Chris. Yes, while we don't know the exact groups that will be recommended for those very first allocations of vaccines, we are able to anticipate what some of them will be based on what we know right at this point. And as I mentioned, in the local public health role, what we want to do is look at some of those early groups that are likely to be allocated for vaccine and make sure that between our local public health role and our partners here in our community, that we have groups that are able to vaccinate these key groups. So as I mentioned, we know our long-term care facilities, residents and staff there have been at high risk throughout this pandemic. And so assuring that we have plans in place now for those long-term care is really critical to getting it out as soon as possible. And the same thing would go for our healthcare workers, that we know they are also one of those early groups. And as I mentioned, what we often refer to as mission critical, or some of those first responder groups. And so that phase one planning right now, anything that we can do now to anticipate and have plans in place so that we know who is likely going to be able to run those clinics and get that vaccine out to these community populations as quickly as possible, that planning now is really going to pay off once that vaccine becomes available.
If everything goes as planned and we do have enough supply, in a best case scenario, how long do you anticipate phase one lasting before you can get to, oh my goodness, I'm going back up here in my notes, down to phase two where you have mass clinics?
Well, I think the key is that the number of individuals who fall into the many categories that you just heard us discuss, it represents, even in Minnesota, hundreds of thousands of people. So phase one could take a while, because the goal of phase one is to make sure that we've addressed essential and mission critical staff, as well as individuals who are at highest risk for severe COVID. And so in order to get through those populations, it could take a while. It really depends on the volume of vaccine that has been approved and is available through the pipeline. I think it's definitely a situation in which we are providing you the preface, or maybe the first chapter of a book that will have many, many more chapters written, and we will continue to provide you updates as we learn more about what vaccines become available and what the timing may look like.
Great. Thank you, Chris. Thank you, Christine. Appreciate it.
Operator, we have time for one more question.
All right, our last question comes from the line of Tom Holster from KSTP. Your line is open.
Hi, thanks for taking my call. Question about the number of deaths. It seems that what is driving this is largely, again, long-term care. About 80% of the deaths in the last 3 days and about 70% over the past week. Do you have an explanation for that? And does this indicate that maybe that battle plan for long-term care is not working?
Hi, this is Commissioner Malcolm. I'll start and certainly invite Chris to chime in. Actually, certainly the increase in cases in long-term care that we've been talking about for some weeks now, as we've flagged that as a concern, that it is pretty darned impossible to keep the virus out of long-term care settings with this degree of spread all over the state, with community transmission of unknown origin, with healthcare workers getting exposed, likely being asymptomatic, not knowing they've been exposed, bringing the virus back into these facilities. That is what seems to be driving the increase in cases. So to that extent, I don't think it's that the battle plan isn't working. I think it's that we've got widespread disease all over Minnesota, which is affecting all kinds of different sectors, and including some of our most vulnerable people. That said, I think it absolutely is appropriate that we take a look at the battle plan, see how we might refresh it, see what else we might need to do just to respond to the reality that this virus is so widespread. One of the dilemmas we've talked about is that balance between trying to keep the virus out of these facilities and the importance of family members being able to visit, and the importance to the health and well-being of the long-term care residents to be able to see family. And that's just a really vexing challenge, but a critical balance to try to get right. So, I think we are doing our very best, and I think when you actually put the numbers in context, though the growth in long-term cases has been steady, it is actually quite a bit more stable. The rate of growth in long-term care cases looks a lot more stable than the overall rate of case growth in the state as a whole. But just given the fact that folks of advanced age and with underlying health conditions tend to have more severe disease, be more likely to be hospitalized, and much higher rates of mortality, even a modest rise in long-term care cases does result in additional hospitalizations and deaths. But we actually are doing some more kind of digging into the data and plan to do probably another update more specific to what we see in long-term care in the coming days. So appreciate your question, Tom. Certainly a fair one. We're looking at it really hard. But again, I guess I would just say, I think the long-term care sector is still doing really a very good job in very, very trying circumstances, given the degree of spread around the state. But Chris, anything more you'd want to add?
Yeah, I do have a follow-up for Chris, but go ahead, Chris, and then I got a quick follow-up for you.
Okay. Yeah, I want to reiterate what the commissioner said, that even with the best battle plan in place, with the level of widespread transmission that we're seeing statewide, you can't keep it out of long-term care. But a couple of the things that we have done, we've reached out. We're working with our long-term care partners actually on an extremely regular basis, weekly basis, but we've also reached out to, reiterate some of the best practices to them, recognizing that they too are likely to experience COVID fatigue like the rest of us. But I want to acknowledge, as the commissioner said, that when we look at the trajectory of our long-term care cases compared to the overall curve of the outbreak, we are not seeing, although we're seeing increases in that population, it is not nearly at the level or at the same rate of increase that we're seeing overall. And I want to acknowledge that when we've done a comparison of the number of new cases in staff versus residents, what we've seen is that during the early months of the pandemic, we saw more cases in residents, which likely reflected more transmission within the facility. And now what we're seeing is many more cases in staff and fewer cases. We're seeing cases in residents, but a lower proportion overall, which suggests that many of the infection prevention measures that facilities have been working on, the use of personal protective equipment, that is all making a difference in limiting transmission. So I think that those are, important points that, we can't, if there's a huge, a lot of spread in the community, we can't necessarily, keep it completely from these facilities, but they have been doing a really great job of using the tools that they have, and the data suggests that is working. But I think the reality is that unless we change the external spread, we're going to be dealing with these challenges for our elders.
And Chris, just a real quick follow-up. I know time is running short. Do you have an update on the percentage of the people who are dying from COVID-19? What percentage of them have a significant underlying health condition, whether it be long-term care or something else significant? And then also these dates or these deaths, it's 35 one day, 5 the day before, 17 the day before that. Are these deaths happening over a period of time, or do you have a better breakdown on the dates these deaths are actually happening?
We report the deaths as they are reported to us and as they come through our system. So I think that it's fair to say that the 35 deaths that we are hearing about, while they did not happen today, this is not a month's worth of deaths getting reported in one day. People need to realize that the death count is going up, and this is not a backlog. This is just the reality of the very, very high case numbers that we're seeing. So obviously, there's a bit of a time delay in terms of, as they get reported and someone dies and it gets reported to us and goes through our system of evaluating. But I do want to be clear that this cannot be explained away by a backlog. And I just am wanting
on the underlying health, yeah.
Yeah, and I think what I'll need to do is I'll need to get that to you offline, because I think we're running out of time, and I'm just pulling it up here. So let me.
Yeah, I think it'd be interesting if. Okay.
Oh, okay. Well. Yeah.
If we could get it so the people listening could hear, that would be helpful if it doesn't take too long.
Okay, I'm just.
While you're looking,
this is Jan. Yeah. Well, I'm sorry, Tom. While Chris is looking, and just to, I think it's certainly true that people with underlying conditions are at higher risk. But another thing we just keep reminding people is we're talking about over half of the adults in Minnesota that have some existing chronic condition. So it's not a small number of people who are at risk through that lens.
Yeah, and I do understand that. Do you have the number, Chris?
No, Tom, I'm pulling up the data that I always pull up, and our form has changed, and so I can't find it as quickly as I have in the past. So this is not an attempt to not share this with the public. This is just the function of me trying to scroll through data while I'm live to the media. And so we will get this to you. I do know that what we have seen I can tell you this in the broadest sense so that everyone can hear this. In the broadest sense, in the very earliest days of the pandemic, nearly all of our cases, our deaths had underlying health conditions. And over time, we've actually seen that decrease. And so we will get that for you, but we have seen a reduction in that. So rather than having all of the cases have underlying health conditions, we actually have had more, I keep saying cases, I should be saying deaths. We've had more deaths in individuals without an underlying condition. But we will get that for you.
Okay, if you could email that, then we will report it. Thank you very much.
Yeah, thank you.
Okay, that is all the time we have for today's call. Obviously, if you have any other questions, please call our communications office this afternoon. Have a good day, and we will be back with you again on Friday.
This has been a WDIO News Special Report.